Good morning, teachers and my colleagues. I'll be presenting question 9. Can you hear me?
Yes, we can hear you.
Okay. I'll be presenting question 9 of the West African College of Physicians, April 2021 General Medicine question. Okay, so the question is, CT scan showing subarachnoid hemorrhage, 20-year-old female, severe headache, vomiting, blood pressure 185, 100 millimeters of mercury. A, list 5 risk factors in her that predisposes her to SAH. B, how would you manage? C, list 2 complications and manage them. D, what is the pathophysiology of hyponatremia and SAH? So this is just a CT scan showing subarachnoid hemorrhage, not filling the subarachnoid systems and into the Sibian fissures bilaterally. We also have intraventricular blood here with enlarged temporal horns. So this is just a picture, a table showing the different features you could see on CT for a patient with aneurysmal bleed. So you have for all forms of aneurysmal bleed, you could have preponderance of subarachnoid blood in the basal systems, then also interpennicular systems, subarachnoid blood in the interpennicular system. Then you have for focal subarachnoid blood in peripontine area. This is for the perimencephalic form of subarachnoid hemorrhage with good prognosis. There are other features you could see based on where the aneurysm is. So this is another diagram showing for the patient with subarachnoid hemorrhage, there is hyperdense signal. You can see the light gray matter here, which will be dark gray, indicating the presence of CSF. So mention 5 risk factors in this patient. Hypertension, I just put all the risk factors here. Hypertension, smoking, heavy alcohol use, sympathomimetic and recreational drug use like cocaine, female sex, family history of subarachnoid hemorrhage, ADPKD, heterovenous malformation, coarctation of the aorta. So how will you manage this patient? Your treatment goals is to maintain euvolemia, euglycemia, pneumothemia, eunatremia, because your patients are at risk of developing cerebral salt twisting syndrome and SAH. So you want to prevention of seizures, good blood pressure control, prevention of vasospasm, maintenance of cerebral perfusion, and management of intracranial pressure. So it's important to remember that management is multidisciplinary. So as you're trying to maintain your treatment goals, you also have to send consults to the neurosurgeons and then interventional radiologists. And you want to admit these patients in the neurological critical care unit. Then you have to set up measures immediately to prevent rebleeding, because rebleeding is a life-threatening complication that most commonly occurs in the first 6 hours after subarachnoid hemorrhage. So start measures to prevent rebleeding immediately. So how do you want to investigate the patient? Investigations to confirm your diagnosis. You want to do a non-contrast CT scan, where you can see the features we showed before, the blood in the basal system and Sibian fissures. But you know that within 6 to 12 hours of the onset, CT scan, the sensitivity is about 98 to 100%, but after 7 days, sensitivity drops to about 60%. So you might want to do a lumbar puncture to assist or confirm your diagnosis. Then digital subtraction angiography is a gold standard for diagnosis. Then you also want to do CT MRI. That's for subacute and chronic forms of subarachnoid hemorrhage. It's more specific compared to the use non-contrast CT. So other investigations you want to do, random blood sugar, you want to maintain the blood sugar between 80 and 120 milligram per dl. You want to do your arterial blood gases. You want to maintain your PCO2 between 30 and 35 millimeters of mercury, because most of these your patients will need hyperventilation, so you don't want to over hyperventilate. Then you want to do your urinalysis, where you might see material proteinuria suggesting a renal pathology. Then ECG, you will see you might see QTC prolongation and T-wave abnormalities, and this could occur in patients. They could have neurogenic myocardial stoning, which will occur in this patient. So you might see this. Echocardiography will show regional wall motion abnormality, hypokinesia, also systolic dysfunction. Cardiac troponins too might be elevated. EUCI might show hyponatremia or other renal derangement. Then you also want to do a clotting profile. So how will you manage this patient? The primary measure should be initiated urgently at the emergency department. Your brief history and examination to elicit risk factors and etiology and identify complications. You want to do your ABCD of resuscitation. Secure the airway if indicated. If patients are unconscious or have a declining GCS score, manage the airway while considering precautions for intubating these patients, because intubation have been known to increase the intracranial pressure. You want to provide hemodynamic support as needed. You want to maintain evolemia. So you want to maintain the central venous pressure between 5 to 8 millimeters of mercury, not in a quiet room, strict bed rest, and multidisciplinary approach. So you want to do anticoagulant reversal for patients on warfarin. I want to give vitamin K or prothrombin complex concentrate. You want to manage the blood pressure and cerebral perfusion pressure. You want to give your IV antihypertensive agents. You want to maintain blood pressure, systolic blood pressure at less than 160 millimeters of mercury. And you want to maintain your mean arterial blood pressure greater than 90. For pain, you want to start with paracetamol. If that's not enough, you could go to your opiates. Then close monitoring of the GCS, pupillary response, as well as vigilance for focal neurological deficits is important, because a drop in GCS is your first sign of complication. So other forms of management, you want to keep patients' core temperature at 37.2 degrees Celsius, elevate the head of the bed to facilitate intracranial venous drainage. Emergent ventricular drainage by the neurosurgeon may be necessary for patients that have acute hydrocephalus. So we've talked about maintaining blood sugar. So you want to avoid overhydrating your patient because of the risk of hydrocephalus. Then patients with SAH may also have hyponatremia. From cerebral sulfate syndrome or SAH. So other measures you want to prevent rebleeding. We said this, you give your patients two softeners so that they don't strain. If there is neck pain, or you can sedate your patient mildly. You don't want to if you sedate them so much, you might not be able to monitor change in their neurological status. You want to maintain adequate input and output monitoring. If fever is present, you compensate for any negative fluid balance, monitor electrolyte, where you might see hyponatremia, then blood count, leukocytosis. So we've talked about blood pressure management. So respiratory, you want to also monitor the heart rhythm, respiratory function, and these are crucial because of the risk of cardiac arrhythmias and pulmonary edema. So vasospasm remains the leading cause of morbidity and mortality. So you also want to give your patient calcium channel antagonist like nimodipine, 600 milligram for hourly. It improves outcome by preventing ischemic injury. So also other measures to prevent vasospasm, we also want to maintain your normal volemia, normothermia, and normal oxygen saturation. So for surgical management, we offer your patient clipping, endovascular coiling, proximal ligation of the parent artery, balloon occlusion, or wrapping or coating of the aneurysms. So the indications for surgical clipping for mild / intermediate grade subarachnoid hemorrhages, grade 1 to 3, large or giant aneurysms, wide neck aneurysm, mass effects or hematoma associated with aneurysms, recurrent aneurysms after coil embolization. For endovascular coiling, used for grade 4 and 5, medically unstable patients with early vasal spasm. So mention two complications and how would you manage them. The first complication is rebleeding. So the greatest risk of bleeding occurs within the first 24 hours of rupture. So measures to prevent rebleeding: nurse your patients in a quiet room, give softeners to prevent straining, give seizures. You can use phenytoin, but the use of anticonvulsants is controversial because some schools of thought, the American Stroke Society advocates that you give prophylaxis, because if the patient has seizures, the chances that the blood pressure will go up and the patient will bleed. So blood pressure control, stool softeners, so that then offer your patient clipping or coiling. Then antifibrinolytics too have been shown to reduce the occurrence of rebleeding. Then for raised ICP, patients with signs of, that's the second complication. So patients with signs of raised ICP or herniation, you want to give hyperventilate these patients. You might use your osmotic diuretics like mannitol, give your loop diuretic. Nurse.
How do you do your mommy?
Nurse at 30 degrees.
How do you do?
Are you having two devices?
No.
Okay, continue.
Yeah, hand. Fish hand.
It's mommy's own.
No.
Hello, Dr. Gift, are you there?
Hello, can you hear me?
Yeah, we can hear you.
Okay. So hemicraniectomy, you can offer your patient hemicraniectomy. That's a compressive craniectomy might be needed for ICP, controlling the setting of, and this is done in the setting of intracerebral hemorrhage and severe cerebral edema. You also want to offer your patient ventriculostomy for patients who have developed acute hydrocephalus. So the next question is, what is the pathophysiology of hyponatremia in subarachnoid hemorrhage? So hyponatremia is common following subarachnoid hemorrhage and occur at different stages of the acute clinical course. And there are two different mechanisms which hyponatremia could occur. So the first is the cerebral salt wasting syndrome, and the second one is the syndrome of inappropriate ADH secretion. For cerebral salt wasting syndrome, there is excess secretion of natriuretic peptides, and this diminishes the central sympathetic activity. It is characterized by volume depletion, which leads to release of antidiuretic hormone. The other mechanism is also impaired sympathetic neural input to the juxtaglomerular apparatus, and this will lead to reduced proximal tubular sodium urate and water reabsorption, and also decrease in renin and aldosterone release. So for SAH, there's intracranial hemorrhage and repair, also repair of the aneurysm, who have also been known to cause hyponatremia. So this interrupts the neural communication and hormonal feedback mechanisms in the brain, and there's also stimulation of the hypothalamus after trauma and then ischemia, and all this will lead to high levels of SAH. But it's important to differentiate the SAH from cerebral salt wasting syndrome. But using laboratory investigations, both SAH and cerebral salt wasting syndrome both cause low serum sodium, high urine sodium, low serum osmolality, and high urine osmolality. So it's difficult to use the laboratory investigations to differentiate these two. But the most important distinguishing features for these two is that patients with cerebral salt wasting syndrome will have a reduced intravascular volume. They usually have hypovolemia. So urine measurement of urine output is very important because patients with cerebral salt wasting syndrome will come with will have polyuria. So it's important to differentiate them because the management too is different. So I'll talk about subarachnoid hemorrhage. Acute bleeding into the subarachnoid space can have multiple etiologies, but by far the most common and most severe form is a non-traumatic spontaneous subarachnoid hemorrhage. And it has a case fatality rate of up to 51% with long-term disability in 1/3 to 1/2 of all survivors. The most common cause is a ruptured subarachnoid hemorrhage, the ruptured cerebral aneurysm. Okay. Then the sites of aneurysm, 80% occur in the anterior circulation, 20% posterior circulation, and the anterior circulation is mostly the anterior communicating artery, where it occurs in 40% of the time, junction of the posterior communicating artery with the internal carotid, where it occurs in 20%, then bifurcation of the internal carotid and the middle cerebral artery, where it occurs in 20 to 25% of patients. Then the incidence of unruptured intracranial aneurysm far exceeds that of subarachnoid hemorrhage. Only about 0.3% of aneurysms rupture every year. So some risk factors that predispose the patients to rupture, if the aneurysm to rupture, is hypertension, age, larger aneurysms, also the aneurysmal location and size. We talk about risk factors. So the clinical presentation and diagnosis, okay, 70% of patients present with severe, with sudden headache. Then some can also present with the sentinel headache that precedes subarachnoid hemorrhage by days to weeks. Although some schools of thought believe that the sentinel headache represents just a minor rupture with a minor bleed before they finally come down to full-blown rupture. So what headache suggests the presence of subarachnoid hemorrhage? Because you have to think about whether you're going to pursue some invasive diagnostic modalities for a patient who just comes and complains of headache with no other neurological symptoms. So we have the Ottawa SAH rule, which is a validated rule used in emergency to be able to say which patient you want to screen for that for subarachnoid hemorrhage, and it has a sensitivity of 100%. So the Ottawa subarachnoid hemorrhage rule is used, it applies for patients who are older than 15 years of age with new severe non-traumatic headache reaching a maximum intensity within 1 hour. So if a patient investigates if one or more high-risk variables are present, age greater than 40 years, neck pain or stiffness, witnessed loss of consciousness, onset during exertion, thunderclap headache reaching its maximum intensity within 1 minute of onset, and limited neck flexion on examination. Okay, so we said worst headache of the life. Patient will say this is the worst headache of their life, sentinel headache, etc. Those ones it occurs just in 40%. Then for patients who are already being managed for headache, maybe patients with migraine or other headache disorders, and they will tell you that this headache is different from the quality and severity of their baseline headaches. They will also have nausea, often with vomiting, sudden loss of consciousness, transient syncope, acute onset of progressive altered mental status. Then when you examine, you might find altered mental status, abnormal Glasgow coma. So other things you could see when you examine the patient, you could see find focal cranial nerve pulses and hemiplegia. There could be meningeal dust, neck pain, and photophobia. Then you could see the Tesson's, what we call the Tesson syndrome, which is intraocular extension of the subarachnoid hemorrhage. So you could do, some of them might present with acute hemiparesis or hemiplegia, seizure-like events, focal neurological deficit. Then some systemic manifestation, you could have acute hypertension, cardiac arrhythmias, cardiac arrest, hypotension or shock from neurogenic stunned myocardium. Then hypoxia could occur from aspiration, respiratory depression, or neurogenic pulmonary edema. So there are some form of severity grading scales that you could use. And this is we have the Hunt and Head scale, and also the World Federation of Neurological Surgeon scale, where you have 1 to 5 asymptomatic or mild headache. I think we can look at this later. Talk about the investigation. Okay, talk about the non-contrastivity being sensitive within 6 to 12 hours, then it decreases. Then you also have, okay, we've talked about this. Investigations for subacute or chronic, you want to do an MRI, which is more specific. So you also have radiologic severity grading skills. The other one we looked at the Hunt and Hairs, and the other one is for clinical severity, but you also have your radiological severity grading skills, which is the modified Fisher and the Hydra skill. So your lumbar puncture could be done in cases of negative or equivocal imaging and high clinical suspicion for subarachnoid hemorrhage. The classical diagnostic criteria is the presence of xanthochromia on laboratory spectrometry analysis. So you might want to do a lumbar puncture, and also lumbar puncture will also help you measure the opening pressure, which is a surrogate for raised intracranial pressure. So when you do that, then there's xanthochromic spinal fluid peaks in intensity within 48 hours and lasts for about 1 to 4 weeks. Then it's also important to differentiate traumatic tap, to exclude a traumatic tap when you're trying to do a lumbar puncture to make a diagnosis of subarachnoid hemorrhage. So how do you do that? The classical puncture findings for subarachnoid hemorrhage are elevated opening pressure, elevated red blood cell count that does not diminish from CSF tube 1 to 4, and your xanthochromia. So the differential for red blood cell counts between tube 1 to 4 can help you. Okay, so for subarachnoid hemorrhage, you expect that there's no decrease in the red blood cell count from the first tube to the fourth tube. Then you know that SAH is more likely, but for a traumatic tap, there will be more red blood cells in the first tube when you compare that to the last tube. So other investigations you need to do, because you stabilize your patient, you've done your non-contrast CT to confirm your diagnosis, you've done your lumbar puncture. Now you need to know where the bleeding is. So the vessel imaging to identify source of bleeding, you want to do a CTA, and there's CT angiography. It has a sensitivity of about 90 to 95% in detecting intracranial aneurysm, but digital subtraction angiography remains the gold standard. But we should know that a negative CT angiography is insufficient to rule out the presence of bleeding aneurysm in patients with subarachnoid hemorrhage, because if you have a small bleed, a bleeding aneurysm that is smaller than 4 cm, might not be picked. So the patient will still have to go on to the DSC. So treatment, we've talked about acute pulmonary failure you want to treat, acute hydrocephalus, decrease diffuse cerebral edema, aneurysmal rebleed. So acute symptomatic hydrocephalus can develop within minutes to days of aneurysmal rupture and it occurs in 20% in patients. So you need to the timely insertion of the external ventricular catheter for acute symptomatic hydrocephalus is life-saving. For the cardiopulmonary dysfunction and cardiac arrest with aneurysmal subarachnoid hemorrhage, cardiopulmonary arrest may present with mild initial symptoms, but then acutely deteriorate, often becoming because of the aneurysmal rupture or acute hydrocephalus. So your patients, in 30% of patients in whom severe cases can lead to significant reduction in ejection fraction and also cardiogenic shock. And this is due to, and is referred to as neurogenic myocardial stunning or stress cardiomyopathy. And it's thought to be secondary to sudden catecholamine surge from the cerebral aneurysmal rupture, leading to myocardial cell contraction and band necrosis. ECG echo talk about diffuse or chronic regional wall abnormality, hypokinesia, cytolic dysfunction. Classical appearance of the neurogenic stunned myocardium is the left ventricular apical akinesis leading to ballooning of the apex during systole, often referred to as cardiomyopathy, ECG, QTC prolongation, T-wave abnormality. Troponins could be elevated in 30% of patients with SAH. So for the acute pulmonary dysfunction, and hypoxic respiratory insufficiency are common after subarachnoid hemorrhage. We have multiple etiologies, respiratory depression, poor airway protection, pulmonary ventilation, perfusion, and mismatch, cardiogenic pulmonary edema, primary neurogenic pulmonary edema. Okay, so for the bleeding, we've talked about the issues of antifibrinolytic drugs like aminocapuric acid can be used, but if you prolong use greater than 72 hours, it's also associated with increased thrombotic complication. Then you want to do your endovascular and open neurosurgical ablation of the aneurysm. It's still under bleeding, vascular coiling. So this is just a table summarizing all the hyperacute things that could occur in your patient and how you manage them. So the delayed brain injury could occur in secondary brain injury could occur in these patients. You have the phase 1 and the phase 2 brain injury. The early brain injury occurs within 0 to 72 hours, and it begins at the time of acute cerebral aneurysmal rupture, which can lead to sudden transient ICP, transient global ischemia, and cell death. While the delayed cerebral injury could occur at 30 to 21 days following the subarachnoid hemorrhage.
Dr. Gift.
Yes.
30 seconds, please, so that we have taken a lot of time.
Okay.
So that we can contribute. Yeah.
Okay. So for the cerebral vasospasm, we have the angiographic vasospasm and the symptomatic vasospasm. For the vasospasm, there is reduction in the cerebral artery diameter of more than 2/3 of the initial baseline caliber. For the symptomatic vasospasm, those are patients, but it's not all patients who have the angiogenic vasospasm that will come down with symptoms. Those who come down with symptoms are said to have the symptomatic vasospasms. Other drugs you could use to treat vasospasms are the Posidil, cilostazol, and the intrathecal fibrinolytics. Okay, so initially there used to be this triple H therapy, which was used to prevent delayed cerebral injury in patients, but it's been known to increase cardiopulmonary complications. It's no longer recommended in the management of patients with subarachnoid hemorrhage. The triple H is hemodilution, hypertension, and hypervolemia. So for seizures, we talked about giving your anti-seizure medication, but it's important to note that some of these patients might have non-convulsive status. So you want to place them on an EEG to also monitor for that. Then fever too would also be common in these patients, and it might be due to infectious, non-infectious, or inflammatory, also you want to treat. Then some patients become dependent. Some patients with hydrocephalus now become dependent, you're not able to wean them off the EVDs, and some risk factors that could predispose your patients to becoming dependent on EVDs. Then it's controversial. Some schools of thought believe that dexamethasone can be used to prevent progression to shunt-dependent hydrocephalus. Then we talked about the pathogenesis of hyponatremia. So cerebral salt wasting could present with high urine output of more than 500 ml per hour. So you might want to give your patient 0.1 milligram to 0.3 milligram of hydrocortisone 2 times a day. And also for your patients with SI, SIDH, management should be fluid restriction, but for these patients, it's not feasible. So you want to correct using your hypertonic saline. So this is how you give your hypertonic saline based on the level of serum sodium. So anemia too has been also controversial, whether you transfuse your patients or not. But with transfusion, there is further depletion of nitric oxide, which will cause some form of vasoconstriction and cause raised blood pressure. For pain, we talked about pain. Some patients might have chronic pain even after the subarachnoid hemorrhage has resolved. So you want to manage the pain. Then this is monitoring for patients with unruptured aneurysms, different 6 months, 1 year. So the prognosis, early mortality in SAH associated with high early mortality rates, long-term mortality. Survivors of neural SAH have an increased mortality rate compared to the general public. The neurological morbidity, long-term complications of SAH include neurocognitive disorders, epilepsy, and focal neurological deficit. Also, memory and cognitive impairment too have also been noted. So in conclusion, SAH is a neurological emergency that tends to affect patients who are younger, females, and continues to cause significant morbidity and mortality. Optimizing good outcome in SAH includes timely and accurate initial recognition, expeditious acute resuscitation and stabilization, minimizing additional brain injury, also neuro rehabilitation, and also future studies to long-term follow-up.
Thank you. Thank you, Dr. Gift, for your presentation. So, Dr. Tanimo, can you go ahead?
Thank you very much. It's an elaborate one. Thank you very much. Can you go to your list of risk factors of your questions? Of the question? The risk factors you mentioned in the question. Okay, so this risk factors, are they for this patient or is for the general population? Because the risk factors they are asking is in reference to the patient, they give the scenario of the patient, not the general risk factors. But
Yes,
I think this one as the general risk factors. You have to modify them so that you select the risk factors that are for the patient alone.
Yes, we don't have the full picture of the question, so I just put everything here. For the patient, it was just hypertension. That was
because the risk factors
so we don't have the full picture. Okay. So I just put all the risk factors here.
Okay, so but if in an exam you have to select the risk factors related to the patient, not the general one. But by and large, it's a very good presentation. Thank you very much.
Yeah, thank you, Dr. Tanimo. From the chat box, Dr. Esther say thank you for your presentation. Kindly explain why female sex is a risk factor. And then what is the dosing for the furosemide? So just hold on, let me read other questions before you respond. Okay, Dr. Momodo say acute lung injury is prevalent about 27% in aneurysmal SAH and is associated with high treatment intensity, longer ICU stay, and unfavorable outcome. So it's one of the complications of aneurysmal SAH. The Oladotun say phenytoin is not recommended Seizure prophylaxis can be done in the first 2 to 7 days, but the evidence is low. Class of recommendation is moderate. It is especially advised when the patient has non-conclusive status epilepticus. Anemia is deleterious as it may predispose to delay cerebral ischemia. So it is advised to optimize PCV to 30%. Then triple H therapy has been abolished. That's hemodilution, hypovolemia, hypertension. And hypertension worsens the anemia and cardiac complications plus pulmonary edema. Then lastly, SAH can be broadly looked at as primary aneurysma, non-aneurysma, secondary trauma, RCVS, ICH, CSBT, vasculitis, endocarditis, and pseudo SAH. And pseudo SAH, that's contrast anoxia intracranial hypotension. Then I'm going to put a picture. Can you put that picture on the group? And then Dr. Antoni says role of antifibrinolytics is not clear. So of course, most of them applauded your presentation. So back to Esther's question. I think she's the only one that asked why female sex is a risk factor. What is the dosing for furosemide? So you can
Okay,
you can answer before Dr. Success will talk. So Dr. Gibbs, over to you.
Okay, for female sex, what I saw is that to having subarachnoid patients that are greater than 50 or postmenopausal patients, they are at risk of having SAH. Then for the furosemide, you always give your furosemide after you give your mannitol. So it's not like you're giving furosemide separately. You give your mannitol, then you give them furosemide to help for the extracellular excretion of the fluid. After you've given your mannitol, you always give your furosemide after that.
Okay, Dr. Success, can you just make your contribution?
Okay, thank you so much, Dr. Gibb. That was Lucy. Thank you. Thank you. You did so well. I just wanted some clarifications from you before I make my comments. Okay, so you said that we give beta blockers as a drug of choice in patients with BP issues in SAH. I saw that in your slide.
Yes.
Yeah, please, we don't, please. Okay, so usually what we give is the CC, the calcium channel blockers. Okay, so in patients that have SAH, then unless you are thinking that they have maybe things like cardiac arrhythmias, okay, but routinely we don't, beta blocker is not the drug of choice. I also saw that you said that the random blood glucose range should be between 80 to 120. So 80 milligram per DL is 4.4 millimole per liter of. Do you want that to be the random blood glucose of your patient, in acute stroke? I think we should actually review that. Yeah.
Okay, what I saw was 80 to 120, but you don't want it below 80. That's what I
okay,
saw.
so 80 is too low.
80 is too low. Below 80.
Yeah, it's too low. Yeah. So, but I will check this thing and send to you the new one. But I think they say it should not get to more than 200 milligram per DL, but 80 is actually on the lower side of. Then you've done well. Let me just comment at once. Yeah. So the risk factor, females having risk factor in SAH. Funny enough, we have not actually known why, but we've seen that in patients with SAH, majority of them, okay, so have a majority of them are females. Even in the last conference we attended, that has not been elucidated, but females have more SAH compared to men. Then for the lady that is 21 years, okay, coming down with SAH, I think another important risk factor should also that we should rule out should be autoimmune diseases, okay, such as SLE. Okay, so that is a very important one we should also look at. Then I want to say that if we are managing a patient with SAH, especially when we want to do neurosurgical intervention, okay, so the size, there are things we put into play, okay, so like the size of the the aneurysmal size, the location, if it's anterior or posterior, if the patient's age, and of course, if the patient has risk factors. Now, why is this important? Now, when you are choosing between endovascular coiling or surgical clipping, there are things you consider. I know you mentioned one or two of them. Well, generally, any of these will depend on the facility, if they actually have, endovascular or surgical. But we know that endovascular coiling is 13 times more expensive than clipping. Okay, so yeah, even if it's better, and these patients, one of the major advantages it actually has over clipping is that it's associated with reduced procedural morbidity and mortality. So when you compare it with clipping, it's associated with lower morbidity and mortality. Now, for patients that are elderly, that have patients that have medical comorbidities, patients that in which their aneurysm occurred in the posterior circulation, you don't want to do a clipping. You want to do a coiling. Okay, so these are some very important indications when you want to differentiate, where you want to do your clipping or the coiling. I remember when we were doing the part one, there's one law we used to call Laplace law, which is important and comes into play when we're talking about the pathophysiology of SAH. Okay, so what's the Laplace law? That the tension, of course, is determined by the radius of the aneurysm and the pressure gradient across the wall. What does that mean? It means that the rate of the rupture is directly related to the size of the aneurysm. Meaning, so when you have an aneurysmal diameter of 5, okay, or maybe of 3 or 4, of course, that is more or less likely to rupture compared to an aneurysm of 10 millimeter. Yeah, you've talked of the vasospasm, which is very important. And you know that when we want to, one of the procedures that we do for vasospasm that is not responding to conservative management is the transluminal balloon angioplasty. I wanted to add that. Then for patients that have SAH, they have poor prognostic factors. You've listed some, let me just list the rest. The location of the aneurysm, that is very important for us. Especially, of course, when the Hunt and Hay scale is also increasing 4-5, it's also a poor prognostic factor. Now, when there's a presence of intraparenchymal blood, even in the ventricle too, they are also associated with poor outcomes, including cocaine use, of course, when patients are more elderly, 65 years, and so on. So even when they have comorbidities or complications like MI, rebleeding, these are associated with poorer outcomes. Thank you so much again for the beautiful presentation. Well done.
Yeah, thank you, Dr. Success. Dr. Yaya.
Well done. Thank you very much. The presenter is very good. Just want to be short because we don't have time. Thank you, Chief Success, for clarifying so many issues. I just want to draw our attention more on the issue of blood pressure. The calcium channel blocker nimodipine is given primarily for vasospasm. They have shown to have very, very low effect on blood pressure. So meaning a patient with high blood pressure coming, apart from controlling vasospasm, which is one of the cause of so many complications that will occur after the SAH, you may also need to treat blood pressure. And some recommend beta blocker actually, because there are a lot of sympathetic output in a patient with catecholamine in excess. So it's better to choose a antihypertensive that have effect on lowering the sympathetic output. And that's where the beta blocker comes in. The calcium channel blocker is 80 to 90% for vasospasm, not the blood pressure. They have a very low blood pressure effect. So patient with higher blood pressure, you need to go for other agent, of which beta blocker is one of the choice. Is very, very important. Okay. Thank you very much. It's a very good one. Thanks.
All right. Yeah, thank you so much, Dr. Yaya. Thank you, Success, too, for coming as specialist. Dr. Gibbs, can you share your screen while I read other, so that the next presenter, please, can you share your slide while I read from the chat box? Okay. Okay, Dr. Adebimpe say use of recreational drug could be a risk factor for SAH in the young. Yes. Dr. Fei say thank you for your beautiful presentation. If BP is not well controlled with nimodipine, what other class of antivirals? Okay, Dr. Yahya just mentioned it. Thank you for the lucid presentation. Vasculitis is also a risk factor for a young female with SAH. Then, okay, Dr. Success has, Dr. Success say, please, what are your principles of management? Okay, is there any question or Dr. Success? I know you just finished speaking now, so. Dr. Olado to say for further learning of risk of rupture of aneurysmal SAH is usually estimated using the acronym phases. Okay, population, Finnish or Japanese at higher risk, hypertension, age greater than 70 years, size of the aneurysm, earlier SAH, site of aneurysm. Okay, yeah, site of aneurysm, then earlier SAH. Okay, Dr. Anthony said there's a confusion on the use of beta blockers. Okay, but Dr. Yahya just, explained to us just now. So, Dr. Gift, Dr. Sophia asking what are your principles of management. Next presenter, please share your slides. Dr. Dr. Taiwo, are you in class? Or Dr. Adebola? Dr. Brown, is any of you in class?
Dr. Brown is in class.
And it's not responding. Oh. Dr. Taiwo, Dr. Adebola. Dr. Brown.
Dr.
Yes.
It would okay, continue what you want to say. I want to say that if there is no presenter, we take the next question. That there's no time. I think this Saturday, next week is the 16th of March. Next week we're ending West Africa papers. By next week weekend, I think most of them should be going for their exam. So there's no time. No time. So if none of them is let's answer the next question, let's move ahead. We don't use it to
So
spoil the
let me
fun.
present my own question.
Okay, Dr. Brown, can you share your slides?
Okay.
So, Dr. Gift, principles of management of SAH, while we are waiting for Dr. Brown to share his slides.
I'm not connected with my laptop before, so let me quickly connect with the laptop and share through the laptop.
Okay.
I think that's the treatment goals of bulimia, glycemia, normothemia, eunatremia, prevention of disease, good blood pressure control, prevention of vasospasm, plans of cerebral perfusion, and management of intracranial pressure.
Okay, thank you. Dr. Success, is there anything you want her to highlight? That's fine.
Okay, hello. That's fine. Gift is I'm thinking she's a neurologist.
Okay.
So mainly we just want to maintain cerebral perfusion. Then, of course, we know that the message is associated with several complications. So you also want to, identify and prevent and then manage complications if they arise. Okay, so BP control is important, the vasospasm that we talk. So control of pain too should also be one of the things we should look at. And of course, it's also, be managed with the neurosurgeons in case there's a rupture, even in the ones that in the aneurysm. Yeah, so multidisciplinary treatment for this patient. Thank you so much. Thank you, Dr. Gibbs.
Yeah, thank you. To success. Dr. Brown.
You can share it on the page.
I'm
Dr.
trying to, okay.
You can share on the
Let me
page.
share it. Let me share it on the page.
Is Dr. Ekele around? Can you help him share the slide or any other person?
Dr. Yaya can help him share.
Dr. Yaya?
Hello, sir.
Yes, we can see. Please complete.
Okay. Yes, we can see.
Okay. Good morning.
Okay, go ahead.
Good morning,
Thank you.
Good morning, everyone. Question 10. Question 10A is on conflict resolution. And the first question is, say you are the chief medical director and there is conflict between lab scientists versus lab physicians. So what will you do? Can I go ahead?
Please go ahead.
Okay. So you are the chief medical director and there's conflict between lab physicians and lab scientists. What will you do? So this scenario is that of a conflict between two professional groups in the hospital. In this case, between the lab scientists and the lab physicians. So using the Lean model, you have to. It's important to resolve this conflict because if this conflict persists, this will affect the provision of laboratory services within the hospital. So you want to call, as chief medical director, you want to call both professional groups to a meeting, to know the source, to know the origin of the conflict, so that smooth laboratory services can continue in the hospital. So you call the representatives of the lab physicians, you also call the representatives of the lab scientists. And then when you call them, you also set rules for respectful communication, so such that nobody interrupts the other when they are presenting their cases. As chief medical director, you listen to representatives of both groups so that you'll be able to know what their grievances are. Having known what their grievances are, you also have to engage all parties, to engage in active listening without interrupting each other, so that you understand what exactly the problem is. What is the reason for the conflict between these two groups? And then the next thing is, how do you now settle this conflict between these two groups of people? Using, there are several conflict in the workplace is inevitable. And since conflict in the workplace is inevitable, it is how you manage conflict that matters. Conflict can be managed for good, and this will lead to avoidance of such conflict in the future. Then if conflict is also mismanaged, it creates problem in the workplace such that it will be difficult to provide services. So these are people that always work together, the lab physician and the lab scientist. So it's important to settle this conflict using a collaborative approach. You know that there are different approaches for conflict resolution. It can be confrontational, it can be avoidance. There are different models, but for this kind of thing, these are people that will always work together. So to settle this, use a collaborative approach. So having listened to both parties on this conflict, you want to seek for areas of agreement between them. Having listened to both of them as chief medical director, instead of both parties quarreling, you want to suggest how they can collaborate and not disagree. So when you hear both sides of the issue, you as CMD, what you do is you now understand the issue. So you cleverly seek for areas of agreement about the problem that can make them work together. Suggest how they can collaborate and not disagree. And then when you are able to now make both parties come to an agreement, both parties can now resume work and now work amicably. That's question one. Question two is about conflict between doctors and Joesu. So this question is very non-specific. I'm sorry, the one in my laptop that I was trying to share, I answered it there, but it's not in this one that is on my phone. I'll still send that one to the group. So this one is non-specific in doctors and Joesu. They actually didn't ask who you are, what role you are supposed to play, but generally looking at it, to solve this kind of conflict too between doctors and Joesu, these are two professional groups in the hospital. So it's still using the same lane model. You want to listen to them, know what their problem is, and then see how you can solve the problem. So for this kind of case, I think this is most likely going to be resolved by the Ministry of Health, and then a committee has to be set up. There has to be a committee, maybe involving the Minister of Health, maybe also involving the Minister of Labor, then other senior officials in the ministry, like permanent secretaries and directors. So these are maybe sometimes, even in the committee, you may even involve someone from the office of the Secretary to Government of the Federation. So as usual, you will invite representatives of both groups to this meeting, listening to the representatives of both groups, and hear what the source of the conflict is. So having heard from both parties, as usual, you set rules for respectful communication while engaging them in dialogue, because that's the only way you'll be able to hear both sides of the issue, and see what the grievances are. So having identified what the problem is from these two professional groups, I think the best way to solve this kind of problem is a long-term problem. It's a long-term problem, so it's not something you want to, you can't use avoidance as a means to solve this problem, not at all. So I think also, this is another area where you want to use a collaborative approach to solve the problem. You want to seek for what the areas of disagreement are, and then see how these disagreements, you can seek for areas of agreement, because these professional groups will always be in the hospital, and see how you can resolve this issue. Also, if it's difficult for you to resolve, if there are areas where you need to apply the civil service rules, you apply the civil service rules, but this question is a a little bit non-specific. They really didn't state. Then question 3, say conflict between a doctor, nurse, pharmacist, and physiotherapist on the ward. How do you solve this kind of problem? Also, you still follow the same model of conflict resolution. You call all these different professionals who are having this conflict. And this is another conflict that you also want to use a collaborative approach to resolve. You want to listen to the cause of the conflict from all of them. And as I've said before, when you call them, first, you set rules for respectful communication, no use of abusive words. All parties must stay mute while the other is presenting his or her case without interruption so that people can communicate respectfully. You want to listen to all of them without interrupting them so that you can understand the problem. When you now understand the cause of the conflict between these different professionals, these are people that will always collaborate and work together. So you now, from having heard from all of them, you now seek areas of agreement about the problem causing this conflict. You, as maybe a chief medical director, they also didn't state your role, but maybe you as chief medical director or head of department of that particular ward where this thing is happening, having listened to the problem, you carefully now tell these people, see how you people can do this work without disagreeing, because you have to find a way to collaborate. This is not something you want to avoid. This will always work together. And it's not something you want to use a confrontational approach. So you seek areas of agreement on how these people can work. Haven't defined what caused the conflict, and then you now, solve the problem from there. Then question 4, say it's a patient with diabetic foot ulcer, abandoned in accident and emergency, because there's disagreement about ownership of the patient among the consultants. As the head of the unit, what will you do? So this particular approach actually requires a confrontational approach. This one is confrontational. You're head of unit, the patient has been abandoned. So you also talk to all the teams involved in the care of this patient. Having talked to the teams involved in the care of this patient, you're head of unit, you now know for example, as a physician, when you listen to them, you should know who should be responsible for management of that patient. So you can take a decision as head of unit that neurology, manage this patient, cardiology, gastroenterology, this is your patient, manage the patient. And you direct the particular consultant in that unit to carry on the management of that patient. If you also see, maybe this person is a diabetic that has some renal compromise, and you see that maybe both endocrinology and nephrology needs to manage this patient, you also direct both unit consultants to co-manage the patient. Maybe it requires 2 or 3 units to manage on one patient. As you deem fit as head of department, you direct them. This is using a confrontational approach. There's nothing to avoid there. This is not something trivial, and you have to resolve this as head of the unit. Then question 5. As a consultant, your house officer came to you to report that she has a heated argument with the ward nurse who refused to administer antihypertensive to a patient because blood pressure was normal. How will you resolve this conflict? This is also not, there's nothing for collaboration here. You also use a confrontational approach in management of this patient, because this is something involving the life of a patient. It's not something where you now want to listen and seek for areas of agreement. No. You call, although you advise your house officer not to engage in such a heated argument, it's not necessary. As usual, you set rules for respectful communication. Then in this meeting, we also use this as an opportunity to educate the nurse that this patient's blood pressure may have just been normal because the patient took the antihypertensive the previous day. And if patient does not take this antihypertensives, blood pressure will go up. So thereafter, you direct the nurse, to administer the medication. That's what you do. As consultant, you direct that nurse to administer the medication. tell your house officer not to engage in this kind of argument. Report to other senior members of the team when some things like this come up. There's no need for those arguments. Those senior people were able to direct the nurse to administer medication. At the same time, you also advise the nurse to always communicate with other senior members of the team where she has.
Can you please round up? It's already time.
Sir? Okay, so I'm rounding up. And then question 6.
Yes, yes.
As a consultant, you prescribe 100 milligrams of Lasix for a patient, and the pharmacy sent it back saying that you want to kill your patient. How do you manage this situation? This is another situation where you need to use a confrontational approach. Meet the pharmacist, engage him in a respectful dialogue, educate the pharmacist that there are indications where such doses of Lasix may be used. Maybe, for example, in patients like acute pulmonary edema, and that you have such a patient. So, and that's the reason why you prescribe this dose. It's not to kill the patient. And that large doses are actually needed to save the patient's life in a situation like this. Having realized that this is not a prescription error, I can assure you that the pharmacist is likely to prescribe the medication. And then let me just quickly round up question 7. Say a patient walked into your office with a serum potassium of 1 millimole from the lab. He requested for a repeat, but the laboratory scientist refused that you are not his boss, and so therefore he will not do a rerun. How will you address this? You report the matter to the supervisor of that lab scientist. We all know that a serum potassium of 1 millimole is incompatible with life, and that this is most likely a laboratory error. So you let the supervisor know. Also let the supervisor know that as a senior consultant in the hospital, you consider the act of this lab scientist unprofessional and disrespectful, and then request for a repeat test to be done, which his supervisor will most likely oblige. Give a verbal warning to the lab scientist, and that should this kind of unprofessional behavior come up later, a written query may be given to him. Thank you.
Thank you, Dr. Brown, for the presentation. Yeah, our time is fast spent, but we still welcome comments, contribution. We see how far we can go with our contributions before our teachers will win. Okay, Dr. Tanimo, can you go ahead?
Thank you very much. It's a very rich presentation. I think for the issue of doctors and GHSU, it's not that the Ministry of Health should know or something like that, because there are local GHSU, there is local in the hospital, all hospital, and other GHSU stepwise to the Ministry of Health, all those ones. So maybe what they are asking is the GHSU in the hospital that you are the CMD. There may not be involvement of the Ministry of Health or something like that. You can solve the issue with the local GHSU you have in your hospital as a CMD, not that your Minister of Health should come into play. But by and large, it's a very nice presentation. Thank you very much.
Yeah, thank you, Dr. Tanimo. Dr. Momodu say, is there room for multiple model approach of corroborating and compromising amongst the various professions in the world? Then Dr. Success, thank you for the lucid presentation. Dr. Charles, say, what does GHSU stand for, please? So, Dr. Brown.
So let me get the first question you asked again, if there's room for what?
Multiple approaches. Multiple model approach of corroborating and compromising.
Yes, yes, sir. There's actually room for that. Depending on what the specific problem is, it's not that every conflict must have just one direct way to tackle it. There are cases where, depending on the problem, you might require multiple models of conflict resolution to tackle the problem.
Okay.
It's not just one model for every conflict.
Okay. So what is GHSU?
Sir?
The next question was, what is JOHESU?
Joint Health Sector Unions.
Yeah.
It's an association comprising all the other workers in the hospital, pharmacists, lab scientists, physiotherapists, even the cleaners, admin staff.
Good, thank you. Any other comments, any other contribution before we hand over to our teachers? Any other? Because the time is fast spent. We are 7 minutes above our normal time schedule. So I'll hand over to Dr. Christabel and our teachers if there are any. Okay, Dr. Fatima. Okay, Dr. Fatima.
Yeah, thank you, presenter, for that wonderful discussion. I want to draw attention. The Lean model, you have never told us the full meaning of the Lean. It actually means listen, empathize, explain, then negotiate, I think. So when handling issues of conflict, you don't just report this to that. No, it's a formal thing that you have to set up a committee involving the person that did the mistake. For instance, the nurse not given the medication, lab scientist not running the samples again and all that. So you must involve the person that did the mistake and as well as his head. Then when the problem cannot be solved at that level, then that means you have to go to a higher level of involving the hospital, other committees in the hospital, you understand? So for instance, if you are looking at the Lean model, you listen to both parties separately. You don't just bring everyone all together at the same time. You listen to both parties separately first. You understand what the problem is actually, what exactly the problem is, after which you bring those parties together, then listen to both of them together. You know you have listened to them separately. Then from there, you may understand whether someone is lying, telling the truth or not. Then you discuss it and set up a formal agreement. You set a formal agreement in form of writing. You understand? This is where each group might have to compromise. So you don't always have to use a one model. Hello?
Yeah,
So
we can
you
hear
may
you.
not have to use one model. So you now write a formal written agreement. You set up rules. You identify the role of each party. You bring out the roles of each party, make everyone understand what exactly his role is. Then you write a formal agreement that must be followed henceforth. You understand? You also assign a supervisor that will make sure those things that you agreed on are being followed. So that is something about the Lean model. Concerning the nurse that didn't administer a drug also, you involve the in charge of the nurses in the ward, you involve the in charge, you also involve the nurse. The most important thing is not just directing the nurse to administer the drug, no, to educate that nurse, including other nurses in the ward or even other nurses in the hospital. The commonest reason for not admitting this drug is because she doesn't have the knowledge. She doesn't know why you are giving the drug. There was a time we had a nurse that set IV fluid normal saline for a patient that was in cardiogenic shock. So our prof called her attention about this. She was trying to tell the prof that she was doing the right thing. So it became a big issue that a meeting has to be set up for them to understand there are different types of shock and there are different lines of management for the different types. You understand? So you involve the nurse, including other nurses, educate them. Once they have that education, then it will be easier for you to have this problem not recurring again, but not just directing her to go and give that drug. That is one. Then about the pharmacist saying that the drug is also going to telling the patient that he is trying to kill the patient. That is a very big issue that you may even have to involve the legal department of the hospital, because there's a serious implication on you. You don't know what might have happened if that patient has died or something terrible has happened. So you must involve the pharmacist, including their heads, educate them. Educating them is also very, very important. Let them know the indication for giving such drugs, why it's been given and the doses that might be that is possible, that as much that the drug can be given as such a high dose, meaning that it's safe. So educating the pharmacists, not only that one that did the mistake, but including other pharmacists in the hospital, that is very, very important. I think these are some of the few things that I can remember that need to be addressed. So thank you.
Yeah, thank you very much, Mark, for a very rich contribution. So I'll hand over to Dr.
Hello, Dr. Atta. Hello?
Yes, ma'am, we can hear you.
Okay, thank you. So I want to thank the presenter. Please, the last one, before I forget. You didn't talk about no national West Africa. They have their own method of dealing with things. This is a West Africa question.
Most of you say?
This, Dr. Atta,
Yes, I think we can hear you.
this is a West African question. West Africa don't use the lean method. They use the Thomas Gimas method. And you didn't mention it at all. And you know, these guys have a question, what they call that, a score booklet, where they wait for you to say some specific things. So if they don't yet, I remember when we went for management course in West Africa, they kept saying, use specific terms, use specific words. Sometimes they'll ask you a question and you give wonderful answers. They'll score you low. Tell you why. Because you did not use specific terms. So I think it was the middle discussion. He started talking about compromise, you know. Those things should have come in from the very beginning. Let them know the Thomas Gimas method of conflict resolution. They don't use lean for West Africa. National use lean. If national bring this question, no, you use the lean approach. If West Africa comes with it, no, you use the Thomas Gimas method. That's what they want to hear. And sometimes they might ask you, why do you choose a method over another method? And you know, sometimes in these questions, you can go all through all five, depending on the scenario they create for you and depending on the person's response. So that's that on the question. The first presenter, she asked this very poor